No, you try, and it depends on your philosophy. You try, if it's slight, you try to adjust it so they don't appear to have as much of a class 3. But you have patients that have a class 2, class 3, and you really can't do anything about it. The change would be too great, right, to get them into a class 1. So you work with what you can work with to get them closer, but sometimes you can't do it. I'm a firm believer, you'll see when you get downstairs. There's one position that they're going to get you to go to with your patients. The most retruded position of the mandible, right? Because you can duplicate that when you're taking your bite, right? And if you get them back there far enough, you make the bite registration with the IUX, right? And then you cool it down, you put it back in the mouth, and you can get them to go back to that position, okay? I'm a firm believer in doing that up to a certain point or a certain age, okay? So if you would all just take your hand and force your mandible back as far as it can, right? And then close. That's the one they want you to duplicate, right? But it's way, way back there, right? To me, my condyles are trying to explode, right? So now let's say you have a 75, 80-year-old person. Are you going to teach them how to chew again? I'm not a big believer in that. Of course, again, please forgive me, this is a kingism. If the individual has acquired a centric, and they're comfortable with the centric, and they can function with the centric, they just want new teeth, right? Don't try to teach them how to chew again, because those people will come back to your office again and again and again, not liking what they're experiencing. Last thing, and then we'll go. Running out of time? We getting close?
45.
Okay.
Is there any?
If you,
I did. It was about setting teeth, but it's fine. Don't worry about it.
if you don't, what was I going to say? I forgot.
Don't teach them how to
I'm
chew.
doing
Kingism.
Kingism, back to that, but there's so many of them, I don't know which one I was at. Lord.
Don't teach a patient how to bite
Yeah,
again,
yeah.
and
And then,
One again and
I
again.
went on, yeah.
Time frame.
Keep going, I'm still, I'm almost there, yeah.
they won't be
Dislocated
happy with what
mandible.
you've got.
Yeah.
So they'll keep coming back.
I could replay what you said.
Even that's, oh Lord. Anyway, it'll come to me probably about 30 seconds after we all depart. But can you think of anything else? Is there anything you're confused on, gray on?
No need to say it.
Okay?
Okay. I didn't know we had more time. So with setting the teeth, I understand like the rim, we're reestablishing that, like, because it's the patient's collapse, reestablishing pushing out the lips and everything. And so I guess I'm confused with setting the teeth. You said you wanted to establish it straight. Are we gonna see that? Because you know how teeth, like the face, especially the facial, they flare towards the facial.
Mhm.
We're trying to reestablish that, right? Or will
Right.
that be established with our record? Like,
Well, you're
Yeah.
gonna establish that in your rims.
okay,
The flare and everything
with
that
the
you want.
okay.
Was it
And then
15
I'm gonna
degrees?
set the teeth. Huh?
Was 15 degrees that you guys asked us to do, or?
We have references that we give, like if, with this, the anterior, anytime a ridge resorbs, it resorbs up and back or down and back, right? So this ridge is now collapsed. When they build this, they take into consideration the vestibule, the 3 millimeters of land area, and they build this so it comes out like that, right? That's just a basic alignment to fulfill what they're guessing the patient might need. You know, some patients, even totally edentulous, unless their mouth is open, you'd never know they didn't have teeth, because their ridge is so big and bold and bony, right, that they have lip support. So then it's more difficult to set teeth. When they have a collapsed ridge, it makes it more difficult for them to wear an appliance, but also easier for the technician to set the teeth. We have a saying, as far as lap dance. And it goes into a lot of different areas. Sometimes, let me start over again. When you send the case to the lab and you say, Bill, I want you to set up an upper and lower denture, right? It'll take me about an hour to set up the upper, after it's mounted, to set up the upper arch and the lower arch, right? I get $70 an arch, so $140 for setting up upper and lower arch. That's not bad, an hour, it's pretty good income. That's on a ridge that has no grinding to do. We don't have big bulbous ridges, we have fairly resorbed ridges, where I can just remove the wax and use my technique to get the teeth in there. So here's where it comes. Sometimes we had this saying, sometimes you go into the woods and you get the bear. Sometimes you go into the woods and the bear gets you, right? So just because we have to grind every tooth to get it into the position of your rim, it might take us 3 hours to set that case, but we still charge $70 an arch. So you don't always have an easy task. It depends on the patient. Last thing, and I don't know whether I've asked you guys this before. How many people in here, parents, wear dentures? Show of hands. Go ahead, lift them up. Absolutely nobody. Okay? How many people in here have grandparents that wear complete upper and lower? Okay, 1, 2, 3, 4, 5. Is that a whole or is that a half? Half. Okay, so everybody wear a partial. Okay, but you see, upper and lower. Okay. These are not. A lot of people ask me. They say, "Why are we still doing dentures? Right? Why are we learning dentures? Nobody wears dentures anymore, and it's less and less, right? I mean, historically, we're improving oral health. We're doing a lot of things, and people are not wearing dentures as much. And they say, why are we even learning how to do it? Here's why. This is the basis for everything. Even though the patient might not need a denture, but down the road, we're talking about implants, right? That's where the money is. That's where the technology is. That's where the technique is, right? How do you build an implant on an edentulous patient? The start is a denture. You've got to do custom trays. You've got to do a setup, or rims. You've got to do a setup. Then that setup is sent to the lab. Then they scan that, and they build a bar, let's say with 4 implants, maybe 6. But where's that bar going to be? Remember, we are redeveloping the lip line, the lip length, the lip contour, the aesthetics, the phonetics, and the function. We're doing all of that. Where do they put that bar? Sure, if they put it right over top of this ridge, it's going to be retentive. But is it accomplishing the needs of that patient? No. Because when you do implants, you are establishing a new ridge. So if this ridge has resorbed up and back, when you do that denture might be out to here. So when you build that bar might be out to there, right? That denture is going to clip onto that bar. So building a bar for a stable denture, an implant bar for an implant denture, implant retained denture, you are actually building a new ridge. You're establishing everything for that patient. It's not multiple guess. You have to have a denture to try into the mouth to get all of those 3 aspects, aesthetics, phonetics, and function, accomplished. Okay?